By the people, for the people, the gathering to get health care now. Chapter 10. Advocacy and the cooperatives. Improvements in our healthcare system stem from a broader understanding of the economic, social, and environmental factors that determine health. We can change the system by working in our own communities to identify and challenge policies that have profound effects on individual health. For example, there's evidence that social determinants of health, such as poverty, lack of education, and school nutrition, have a greater influence on health than individual risk behaviors. Considering this, it may be possible, with knowledgeable leadership, to eliminate some of the risk altogether and to generally improve health care and reduce its costs. For those people who know about the healthcare problems and the potential solutions, they need to add their voices and their labor to this cause. By organizing local patient-physician cooperatives, we can identify ways that physicians and patients can become involved in influencing community health policy. We can identify and describe the local economic, social, and environmental determinants of health relevant to the area we want to develop. And by organizing physicians and patients around community health issues such as tobacco control, air pollution, food policy, or advertising to children, we can become a voice for change and influence the public policies that influence health. By teaching health care to selected patients who live in the community, they will be enabled to organize their families, friends, and neighbors to join cooperatives with the support of both Eastern and Western trained physicians. The patients trained by these physicians will make up healthcare committees that will make the neighborhood secure so that the physician and nurse can work freely and comfortably in the area. They can accompany the physician and the nurse on rounds to patients' homes to show support and to give confidence to the provider and to the patient. They can help collect and record all demographic and medical data. They can promote comprehensive community medicine. They can promote a culture of wellness. They can analyze data and identify major ailments in the patient population. They can help to fix problems that are identified by using the prescription of the primary care physician and nurse. They can make real work and the people involved accountable. The teaching and evaluation activities precede any delivery and financing for healthcare services. Once a primary care physician is in place and the community health worker team has been trained and deployed, the patient membership can be built in such a way that the physician and the team know every patient on a first-name basis and the medical problems that these patients need help in solving. In that process, the social determinants of healthcare in the community will be well understood by the physician and the cooperative members so that the root causes of bad health can be systematically addressed. Ultimately, this development will allow the cooperatives to achieve goals and objectives not possible in the traditional healthcare systems. These are those goals. Put preventive care first. Train providers to promote comprehensive integration of family health care in community life. Increase the number of physicians per patient in each population until it is 1 for every 150 patients instead of 1 for 417 patients as it is now in the United States. Reduce the cost of drugs by every means possible and introduce herbal medicines to provide alternatives to patients that may not need patent medicines. Place physicians in communities with the greatest needs. Raise the awareness of public health issues to lower mortality and morbidity rates. Have physicians live in the same service areas as their patients to learn firsthand the sources of their illnesses. Increase primary care and improve specialist skills by making primary care their starting base. Start with comprehensive general medicine in neighborhood clinics, and then form basic health teams. A team is a physician and a nurse, and the volunteer health committee of 10 patient members. The physician-trained community health workers, assisted by a specialist team at the diagnostic clinics or specialty hospitals. The local team serves 1,500 patients, about 500 households. Specialty groups at diagnostic clinics can serve patients from 20 of these teams. The physician lives in the neighborhood he or she serves and is available 24/7. The physician and the nurse treat patients both in the clinic and in the patient's home. These providers get all of the vital medical information and record it in the electronic medical records system. The health committee members and the providers teach preventive care to every patient member. Each specialty diagnostic center serves from 20,000 to 40,000 patients. Teams are thorough and attentive to each patient and know them all personally. The patients that are hospitalized are accompanied to the hospital by his or her primary care physician, and the physician consults with the specialty team members that will care for that patient while he or she is hospitalized. Every specialist is also able to do primary care because they did that before becoming a specialist. Medicine in this type setting is a science that is integrated with real-life processes and is aligned with the quantum physics we now assume to be true about our world and about our universe. Unification of problems, identification of problems, and interactive learning are used to increase cognitive independence. Epidemiology and public health are emphasized. This common sense system and its goals cannot be defeated by adversity because it's a continuous process of overcoming problems that are far more complex and closer to the values of each person in the community than any general opposition that will arise because of pride or greed.